Good afternoon, everyone. Happy St. Patrick's Day to everyone joining us, and thank you for joining us for the Government of Newfoundland and Labrador's COVID-19 update for today, March 17th. We've asked Dr. Proton Raman to join us today to share some analysis from the latest COVID-19 outbreak in our province and talk about modeling. But first, I'll turn things over to Dr. Fitzgerald to give an update on the latest numbers.
Thank you, Premier. Good afternoon, everyone, and happy St. Patrick's Day. Since the media advisory yesterday, we have no new confirmed cases of COVID-19 in our province. The total number of cases stands at 1,013. There have been 9 new recoveries, 8 in Eastern Health and 1 in Labrador Grenfell Health, leaving 36 active cases in the province. 2 people are in hospital due to COVID-19, and a total of 120,946 people have been tested to date. We are 5 days into Alert Level 4 on the Avalon Peninsula and Level 3 for the remainder of the province. We will need the full 14 days to effectively determine if there has been any COVID transmission with the increased movement, and we will be carefully monitoring this over the next week. If you have any symptoms, please book a test using our online assessment and referral tool. A new mild cough is enough to warrant a test. We are holding steady, but we saw firsthand how that can change in a day. Remember, your daily interactions should align with what is permitted during your alert level, not your personal comfort level or how many cases of COVID we have in the province. On the Avalon, your contacts should be limited to your household and immediate family, caregivers, or supports where necessary. Off the Avalon, you should keep your contacts to your tight 10. If we keep our contacts low, we prevent widespread transmission of any COVID cases that slip through. Keeping our communities safe means that children can return to school and families can visit their loved ones in long-term care. This is an adjustment, and I know everyone is eager to return to the way things were in the months leading up to the outbreak. But we've learned so much, and to quote Maya Angelou, when you know better, you do better. The lessons we have learned from this outbreak and the COVID variants must guide our decisions going forward. We would be remiss to do otherwise. So we have asked so much of you over the last year, and we continue to ask for your patience and your trust. We will get there, even though it may look a little different than before. There is no doubt that vaccinating a substantial portion of the population is the key to returning to normal. And I'm very happy to report that our regional health authorities are making excellent progress in working through the priority groups. Over 40,000 doses have been administered as of Monday. And this week, Eastern, Central, and Western Health are beginning vaccinations for first responders. Labrador Grenfell Health will begin vaccinations for first responders starting Monday. The process is being coordinated through police and fire employers and associations. Central, Western, and Eastern Health are offering vaccinations to those aged 80 and older this week and expect to start vaccinations for those over the age of 70 by the end of the month. Labrador Grenfell Health anticipates completing vaccinations for those over the age of 70 by early next week and will begin vaccinations for adults in Indigenous communities for the first week of April. As a reminder, if you are a home support worker or someone aged 70 and older, please pre-register for your COVID vaccine so that you can be contacted when we have a vaccine available for you. In an update from the National Advisory Committee on Immunization, the AstraZeneca vaccine is now recommended for use in individuals over the age of 65. This change is the result of new evidence from the United Kingdom demonstrating high safety and effectiveness of the AstraZeneca vaccine in older adults, particularly against severe COVID-19 disease and hospitalization. We are also pleased that Moderna is beginning to study the vaccine in children. Children represent a substantial proportion of our population, and a vaccine for this age group is an important step in achieving herd immunity. As a recap for those who may have just joined us, we have no new confirmed cases since yesterday's media advisory, and the total number of cases in the province is 1,013. We must all do our part to keep COVID-19 at bay and prevent another outbreak. So please stay vigilant, be kind, and hold fast, Newfoundland and Labrador. Thank you.
Well, thank you, Dr. Fitzgerald. We've had a good few days in a row of 0 or single-digit numbers in our province. This is a trend we all want to see continue. Vaccines also continue to roll out with people over the age of 70 starting next week. But again, from everything we've learned in the last year about COVID-19 and with the recent outbreak that brought us back to alert level 5, now is not the time for celebration. It's the time for constraint. And I know it's hard given that today is St. Patrick's Day, but please try to keep celebrations safe, bubbled, and socially distanced. With that, I'll turn it over to Dr. Haggie for some brief remarks.
Thank you very much, Premier. I usually start off with a number, so I'm going to give you one. 36,642. That's the number of people as of yesterday morning who had been vaccinated with 1 or 2 doses across the province. Phase 1 of the vaccination scheme is drawing to a close. We have had excellent registration for Phase 2 in terms of our senior population. In actual fact, we've had pretty well 100% in those aged 75 and over. Phase 2 is already starting, and we've seen that with some of the AstraZeneca that started being distributed yesterday and administered in Central Health to first responders. As our vulnerable folk become protected and as the incidence of active cases goes down, I think it is time to look up a little bit and bear in mind Dr. Fitzgerald's advice about the present. But I think the new summer that we will see this year will turn out to be a better one than last year. And I think it will probably be able to start around the usual time as long as these trends continue. I think it is a testament to all of us in terms of sticking with what has been a difficult regime of public health measures. So with that sort of hint of optimism and a look to the future, I'll turn it back to yourself, Premier.
Well, thank you, Minister. I'll now invite Dr. Proton Raman to provide an update on COVID-19 modeling in our province. Dr. Raman?
So good afternoon, everyone, and happy St. Patrick's Day. Sorry, I see a really nice picture of Minister Haggie here, but not my slides. Thanks, Derek. Perfect. So thanks, Premier, for allowing the Predictive Analytics team to give a COVID-19 modeling update. So this is the work that's done on behalf of the team. We have a really talented and well-experienced group, mostly from the faculty from Memorial University, also from the Newfoundland Labrador Centre for Health Information, with expertise in terms of mathematics, statistics, as well as advanced analytics. So this is a team effort. So the key points that we would like to talk about today is just looking at what's happened over the year. You'll see that the Newfoundland COVID-19 dynamics are dominated by 2 community outbreaks that spread rapidly. And that's something we always need to be vigilant about, is regarding these super spreader-like events that can always happen. Secondly, is that there's been minimal community transmission, really due to effective containment of cases related to importations. We've done really well in limiting community transmission from the imported cases that we've had. Unfortunately, there was a recent outbreak with the B117 variant, and what we've learned is that that can spread very quickly. But on the flip side is that public health measures were very effective in controlling the spread of B117. So we can control it if we listen diligently to the advice from Dr. Fitzgerald and her team. And finally, I realize the sense of optimism, and I share it as well, but still we need continued vigilance to maintain the minimal community transmission and to also minimize the probability of future outbreaks. So those are the things we're going to highlight briefly. So regarding the epidemiology, so when you look back over a year, this is the slide that you see, and the 2 focal points for some would be the 2 outbreaks, one in March and the other one in early February of this year, and we'll talk about the one in February in detail in a few more minutes. But the other story is actually what happened in between, and that's excellent community control due to the compliance among Newfoundlanders and Labradorians in not letting the virus spread within their community. So what has this resulted to? When you actually look at our province as compared to other provinces, we've done exceptionally well. And so this is due to the collective efforts, again, of the Newfoundland and Labradorians, and also with very good, appropriate public health measures, and just the combination of the 2 things. So let's look back over the year, and the deaths, I realize, are a crude indicator, but they're still important to look at in terms of what's happened over 2020. So the first thing to realize when you're trying to predict how many people would pass away in a given year is to look back at the trends. So if you look at a 40-year trend for Newfoundland and Labrador, unfortunately there are more deaths in every succeeding year due to the older population. Also, if you want to predict deaths over months, because over a year may not be sensitive enough, you have to appreciate that there's less deaths in the summertime and more death in the winter, likely due to the flu season. So taking these two trends into consideration, what we've done is to develop a short-term forecasting, which you see in blue, by month for the year 2020, with confidence intervals around it, is because this is a predictive analysis. Then what we have done is used red dots to mark the actual number of reported deaths that we've experienced during 2020. And so what you see here is that the predicted number of deaths for 2020 is 5,369 using the model that was developed, and the actual deaths reported for 2020 was 5,374. So a slight excess, but not overwhelming. So what this data does not actually have is the granularity regarding specific subsets of individuals or diseases, and so that analysis is still pending. However, overall, there's not been an excess number of deaths compared to what would have been predicted. And this relates to both COVID and non-COVID deaths, and is a reflection that overall our health system was able to tolerate this pandemic quite well. So let's look at the cases from the most recent outbreak. So this is what we're used to seeing, a surge of cases, and this sort of two different sort of cyclic peak. So this was, as you can appreciate, somewhat artificial and in terms of the two peaks, and that's because of the large volume of cases that were noted and the testing that was needed. There was a slight reporting delay. And as a result, just looking at this, it's slightly harder to model. So we actually had to anchor it. So in the subsequent modeling, the best way we thought to anchor this was using the known symptom onset by age group. So if you actually anchor it by symptom onset, so these are only individuals that had symptoms, what you're actually seeing is the typical graph of an outbreak with a very quick rise and then a gradual fall. And so we'll actually use this subset of patients to understand better the dynamics of what happened with respect to the most recent outbreak. So the first thing that you see are that those individuals under the age of 20, the natural history of this virus is to spread, likely gave it to parents or other people within their household or adults they came in contact with, and you can see the pattern of transmission from those less than the age of 20 to those more than the age of 30. This is one of the more important slides that I'm going to show you, and that looks at how quickly the virus took off. It's a very rapid spread, and it was doubling every 2 days. So you can see why swift and decisive health measures had to be taken and when they were done, because if you waited 2 more days, you'd have double the number of cases. On the right-hand side is also a very important story, and that's how effective the public health measures were and how overall everyone complied with it, because the cases decreased by half every 4 days. So this was a scary event, and it was really well managed, and this is what the graph is showing. Another way of looking at it, and that's slightly more technical, is we often talk about the effective reproduction number. And essentially what you want that number to be is less than 1, and then any particular outbreak or pandemic will slowly subside, and this is exactly what's happened. And since mid-February, we have persistently had an effective reproduction number less than 1. The final metrics that's sometimes used to look at how good we have in terms of control for community transmission is to look at the test positivity rate. We've done exceptionally well in this regard prior to the outbreak, with numbers anywhere between 0.1 to 0.2% as the 7-day average. It peaked to about 5%. And just to give you an idea, though, and perspective, Ontario yesterday was 4%. but we've been able to manage the outbreak really well, and we're back to our pre-outbreak numbers of, again, about 0.1 to 0.2% over the last few days. So again, managed the outbreak really well, and we're back to where we were before. Just a couple of slides in terms of healthcare utilization. This slide here is just to make the point that these cases have consequences. So if you see a large number of cases, then there'll be hospitalizations, and some of the people that'll be hospitalized will end up in the ICU. So this was for our first outbreak, and this was for our second. Why is the scale different, or the proportion of people that were hospitalized seems to be greater in the first outbreak? Because this cohort was older as compared to this particular cohort. What's happened now with the experience that we've had nationally and the fact that each of the cases with COVID and the outcomes are logged and made publicly available is we actually interrogate that data to help with our predictions, because thankfully our cases traditionally have been lower. So using those models, what we could do when we actually see a surge of cases is we predicted, and this is in the dotted line, what the hospital occupancy would be with the active number of cases that we saw initially. And you can see it played out pretty well, and the model had a pretty good fit with the actual number, which is in the more solid lines there. The same thing in terms of ICU occupancy, and this is something we follow closely because this is one of the vulnerable points, not just for our jurisdiction, but all jurisdictions in the world. And you can see we predicted around the third week of February, approximately 5 ICU admissions. What we actually noted was 6 for a period of time, but again, a pretty good correlation. So these cases have consequences, but we are able to predict what the healthcare needs are going to be using our analytics. The other thing I wanted to touch on today was the impact of the SARS-CoV-2 B.1.1.7 variant. So there were 344 viral sequences that was sent away, and then subsequently we got the results back. And best to look at it, what happened prior to February of 2021 and what happened afterwards. So in terms of the variants that were noted, the most important thing on the top part of the slide is that there was no cases of B.1.1.7, which is otherwise referred to as the UK variant, no cases of B.1.351, which is the South African variant, and no cases of P.1, which is the Brazilian variant. But as Dr. Fitzgerald and others have mentioned, and we all know by now, the outbreak that occurred in February was due to the B.1.1.7 variant, and we had 178 sequences or cases related to that, which to some extent explains the rapid, explosive onset of this particular outbreak. So let's look at the impact that this particular variant had, because this is conceptually a really important thing to understand, is how the virus is mutated and how we have to think a little bit differently over the next few months as we try to manage this particular outbreak. So this again is mapping based on date of symptom onset, and what the orange dots here are the actual cases that were noted, and then it was subsequently modeled, and this model is slightly different, but what it shows is that the initial increase had a reproduction number of 6.4, and the decrease had a reproduction number of 0.6. The worldwide experience with the B.1.1.7 variant is that it's between 30 to 70% more transmissible. It's easier to catch. So for this modeling, we assume that was 50% greater. Knowing that, we can work backwards and say, hey, in the same setting that this outbreak occurred, if we had the original variant of the SARS-CoV-2, how many cases would we have generated? We would have generated about 1/3 the number of cases that were actually reported, really highlighting that we really have to respect the new variant, because more transmission means more cases means more health consequences. So this is my last slide, and to make this point of what is the potential impact of the emerging variants of concern, such as B117 to Newfoundland? So this is modeled on actual data. So for a 2-month period, for instance, we are reporting approximately 23 imports per month. Those imports sometimes lead to secondary infections, usually due to close contacts, and over a 2-month period, you could have, for instance, 71 cases. This is what's been reported. Now, on Monday, the Ontario Science Table reported that 49% of the new cases that they're seeing in Ontario now is B117. What is the potential consequence? The modelers and the scientists are potentially predicting a third wave in Ontario. It is reasonable to assume that if the numbers go up in Ontario, because a lot of our importations are from that province, we're going to see more cases. For every case that lands on our border from Ontario, from now on, there's a 50% chance that they will have the B117 variant. Our experience with the B117 variant is that it spreads quicker within households. But our other experience with the B117 variant is that we are able to manage and contain this as long as we are stringent and follow public health guidelines. So the most important thing here is to listen to Dr. Fitzgerald and her team. They're guiding you based on the epidemiology they see within the province and what they see outside of the province as well. You know, essentially now it's a race, isn't it? It's a race between injections or vaccinations and infections. And to really help secure the win, what we really need to do is to keep the infections as low as possible so that we can vaccinate many individuals, because by keeping the infections low, we're buying time, and it's time that's going to allow us to vaccinate most of our Newfoundlanders. So in summary, we've done really well in controlling this outbreak. We realize that now, but SARS-CoV-2 infections, including B117, are still expected, and we shouldn't be surprised about that. The B117 variant, as we've seen, can spread very quickly, but the public health measures are quite effective in controlling the spread of all variants of SARS-CoV-2, whether it's the B117, B1351. It's the same things that we have to do, but we have to be vigilant. And this continued vigilance is needed to maintain minimal community transmission and to minimize the probability of further outbreaks. Thank you for your time, and thanks, Premier.
Well, thank you, Dr. Rahman. We'll now open it up to questions from the media.
Thank you, Premier. For the benefit of our speakers, there are 7 reporters registered for today's call. The question and answer session will be conducted in 2 rounds, where each reporter will have the opportunity to ask 1 question and 1 follow-up per round. Following this, I will ask each reporter if they have 1 final question. Our first questions are from Peter Cowan with CBC. Please go ahead.
Dr. Rahman, I'm wondering if you could talk about what modeling you did in advance of the election and whether or not any of it lines up with the assertion that the Premier made in February that there was a prediction of a spike coming in March.
So thanks for your question, Peter. There's 2 different elements to this, right? So in terms of the recent outbreak that was actually seen, this was more like a super spreader event. If we look at the reproduction number, this is really not possible to predict when a super spreader event can occur. This is because these are stochastic or random events. So at the time, we had very good community control, and it's really hard to predict. That is the B117 variant of all the ones that will actually escape into the community, that there would be multiple large gatherings that would actually foster the transmission, occur in slightly younger individuals that are asymptomatic, and that would further increase the transmission. So in terms of outbreaks, these are not possible to model. Our discussions usually for the predictive analytics team is with public health and the Department of Health and the health authorities. I did meet with the Premier on a couple of occasions for general overviews. It really had to do with healthcare capacity. And what we discussed in respect to looking at the second wave in Ontario is that there's a natural order based on community transmission, not on super spreader events, that the doubling time is about 10 to 12 days in terms of cases. So when there's very little in terms of community transmission, it takes a while for the number of cases to get up to a level where it's going to stress the ICU. So the discussion that was had was related to surge capacity, what's actually needed in terms of ICU, how quickly do we have to respond, and these were hypothetical discussions based on data that we're actually seeing in Ontario, but there was no modeling, because what you need for modeling, whether it's short-term forecasting or long-term predictive modeling, are cases to go by, because it's the pattern that we actually use to look forward, and there was no pattern there because we had no cases at the time of our discussion with the Premier. Hope that answers your question.
It does, thank you. Dr. Fitzgerald, I'm wondering, what's your take on all this data that you've been able to sort of digest, and how or what does it change about how you move forward and what measures you bring in or don't bring in?
Certainly when we look at this latest outbreak and B117 and how quickly it spread, and how we saw, you know, a significant amount of asymptomatic or very mildly symptomatic spread, especially in the younger population, I think, you know, that gives us a lot of pause for thought when it comes to how we deal with COVID and the variants of concern going forward. So we have to be a little more vigilant. We know, you know, what's happening, as Dr. Rahman said, what's happening in Ontario, seeing more and more a higher proportion of their cases being related to variants of concern. We know we're going to start to see more importation of variants of concern. So we do have to take that into account when we're looking at relaxing these public health measures and moving forward. So we really have to think about this as we're relaxing our measures in the face of a more transmissible variant, and so we have to do it accordingly. So, you know, that does mean that we're going to have to look at gathering sizes a little more carefully, and those situations where we would have a lot of people coming together for an event. So we have to look at that a little bit more carefully going forward.
Thank you.
Our next questions are from Peter Jackson with The Telegram. Please go ahead.
Good afternoon. Dr. Rahman, we are usually given a heads up when there's going to be some sort of modeling. I'm curious to know how far in advance your appearance here was planned.
So I was asked, I think, a week ago, but there's previous discussions in terms of us coming to model as well, and so a lot of it had to do with other priorities that were there.
Okay. Also, in your presentation, I don't recall whether you suggested the B117 can actually be more severe, which is some evidence that we're hearing. Is that the case?
I think so, Peter. That's my read of the literature, is that when you look at the UK, who's got the best experience in terms of the B117 and a very strong epidemiological group, they are reporting increased severity, not only increased transmission, both in terms of hospitalizations and ICU. And the other thing that we've noticed in terms of the kinetics is that you end up in hospital a little bit quicker as well, but that's somewhat anecdotal because our experience is somewhat limited. But in following the literature, I'm pretty convinced that it's actually a more severe variant as well in terms of complications. So you're right.
Thank you.
Our next questions are from Richard Duggan with VOCM. Please go ahead.
Thank you. Dr. Rahman, the last time that we had a presentation like this, I believe it was either last summer or just before last summer, you mentioned a little while ago that you were asked, you think it was about last week, to put this presentation together. I guess, why do we believe that it was so important for us to share this information at this particular time?
Well, I mean, Richard, there's two things. One was the last time it was presented was after an outbreak. This was after an outbreak. It takes time to see the data in order to determine modeling. So there was an appropriate amount of time for Dr. Rahman to present the current modeling in terms of projections and how we did. No different than after the calls cluster. There was a little bit of time before he presented, and I don't want to speak for Dr. Rahman, but that was the kind of thought process.
So absolutely, Richard, and so it takes a little while for the data to come in and for the models and the analysis for it to work. The other thing, important thing, is that there's a greater sense that we're actually doing well now, and it's also to reinforce and to respect the variant and the potential that another outbreak can occur, that I thought it was quite strategic of the Premier and to sort of have this discussion.
Thank you. Dr. Fitzgerald, it was mentioned in the presentation that, and I believe I heard this correctly, that there's 50% chance that, for example, coming from Ontario, that there's 50-50 chance that case that we get could be a variant of concern. With that in mind, and you touched on it a little while ago about how this information could impact your decision making. With that in mind, with there being a 50-50 chance we see these variants come in from other provinces, how does that impact our decisions in terms of, say, rotational workers and just travel restrictions in general moving forward?
So with regard to rotational workers, obviously that was a big concern for us. We're also seeing increasing rates of variants of concern in Alberta, which is another area where a lot of people go to work. So these are, that was something that we definitely had to take into account. It's mainly the reason why we have instituted testing for rotational workers, because we know that, this, by the time somebody becomes symptomatic with say, a B117 variant, their contacts may already be spreading it. So we certainly saw that in this outbreak. We also saw situations where people did not become symptomatic until quite late in the incubation period. And so, that influenced what we recommended for testing as well. So, this is, the variants of concern has been really factored largely into many of the decisions that we've made up to this point, or since the outbreak.
Thank you.
Our next questions are from Patrick Butler with Radio Canada. Please go ahead.
Hello. I'd like to follow up to do a follow-up on Buchanan's question. Premier, Dr. Rahman just said that he didn't do any modeling of case numbers prior to the election call. If that's the case, what were you talking about last month when you said that you had looked at probabilistic modeling before calling an election?
So two things. One, he said that there was not enough cases to do a predictive modeling. So in the absence of predictions, you need to make decisions. And so I looked at the probability of three different scenarios occurring. One being that we continued as we were, and don't forget, like if we can rewind to the second week of January, we had several days with no cases. We had a total of 5 active cases. The rolling 7-day average was under 1 case per day. So there was one scenario in which that would just continue, and as it had continued for months prior, before actually up until the calls cluster, really, we continued like that with the strict public health guidelines in place. The second scenario was the one that Dr. Rahman just described, which the natural order of this disease, this virus, extrapolated from using the data that was publicly available on the federal government website for Ontario or BC, where you looked at it and you could extrapolate that it would take several, as Dr. Rahman said, several weeks to months with escapes, meaning that people who had it were out in the community spreading it before it reached a critical mass, which I estimated to be between 5 to 10 per 100,000, before it really hit that steep spike of an exponential rise. And so if you kind of extrapolated from the data and where we were at the time, that was potentially months away if it was at all to occur. And the third, the worst case scenario would be if we took the 5 cases that kind of were identified at the time and said that they were going to be out in the community and have a community spread without being recognized, and use the doubling time that existed at that particular moment in time of 12 days and applied that, then even over this time of the election cycle, you're looking at 20 to 30 cases at the most. So I assign probabilities to each one of those scenarios. That's how I make decisions. That's the kind of probabilities that I would apply to different items and models and decision-making moving forward. In the absence of definitive measures and definitive evidence moving forward, that's all you can do. You make the decisions with the evidence available to you. And the second scenario was what led me to believe that there could be outbreaks later in the year.
The issue of transparency has been raised here. The opposition requested this data, me requested it. Does not. Will you release the model?
Sorry, you broke up there, Patrick, but all the data that we used for the decision surrounding the election was publicly available on the federal government website in terms of predictions and current trends. We release every single day the cases in this province. That's publicly available data that we would use to drive decisions. With respect to the modeling, as Dr. Rahman suggested, there was no cases, so in the absence of cases, it's difficult to model, and he even said that back when he presented the last time in May. So that's the publicly available data. The rest of the question kind of broke up there, Patrick.
Sorry, am I allowed to re-ask that then? Sorry. I'll go ahead. Basically, it was just how do you respond to the criticism of transparency from the opposition?
Well, the answer is the same, Patrick. I mean, all the data has been publicly available. It's publicly available data. The cases we report every single day, the number of vaccines we report, we're here with the modeling today to outline what happened in the past outbreak. The modeling that we used even to assess the safety of the election and election timing was publicly available. Transparency, we're fully transparent with the data with respect to COVID-19.
Our next questions are from Jody Cook with NTV. Please go ahead.
Good afternoon. Thank you. Dr. Fitzgerald, the AstraZeneca vaccine, now we know that NACI has indicated that this is to be also included for 65 plus. We've seen some variations on how countries are rolling out or not with this vaccine. What's the plan here and how we see this fitting into Newfoundland and Labrador, and particularly with the 65 plus demographic, when right now we know it's earmarked for first responders?
Yes, so we certainly developed our strategy right now, knowing that the majority of the vaccine that we were going to get in was mRNA vaccine, so the Pfizer or Moderna product, and that has been earmarked for those over 65. Those plans have been put in place. The amount of AstraZeneca proportionately that we're getting is quite small. And so we will be focusing that more on, specific populations, likely in the younger age groups, some essential workers, such as first responders. And that's where we'll be focusing its use going forward. So, our strategy is not changing too much. This is an addition that allows us to get some of those groups done a little bit faster or earlier than perhaps we would have, which is really good. And so that's what we'll be doing going forward.
Thank you. And Dr. Hagee had mentioned earlier the importance of having some hope and looking forward to the summer and maybe returning to a summer that looked even better than last summer. But we also hear, Dr. Fitzgerald, you talk about the importance of vigilance and remaining with these public health guidelines and maybe even enforcing them a little bit greater as we go into the summer. So where do you find the balance there?
I don't know. If you had a crystal ball, that would be great. I think right now, we're learning lots about this vaccine, and learning how it affects transmission. We've certainly seen a reduction in severe disease with its use. which is really good. So that does give us hope that things will be able to get back to normal. But we have to remember that we have to get 2 doses of vaccine, of the vaccines that we have available to us right now. We need to get 2 doses of those into people. And that's going to take us the summer for that second dose. So, you know, we do have to consider that. We have to consider that there is increasing variance across the world and across the country, and that importation is going to result in, you know, we're going to see variants of concern imported, and those are all at this point more transmissible, so we have to consider that. So yes, hopefully we will be able to move forward. We'll have a good summer. You know, we'll be able to do many of the same things that we were able to do last summer, but we do just need to think about how we're going to do that safely. So what we're really looking at now is to try to reduce the harms as much as we possibly can, while still being able to do the things that we were able to do before. And I think that's going to take a little bit of work, both on public health's part and on everybody's part, really, to make sure that can happen safely.
Our next questions are from Elizabeth Witten with All Newfoundland Labrador. Please go ahead.
Thank you. I'd like to know who reached out to Dr. Rahman last week to appear on today's panel.
I'm assuming that came through the Department of Health.
That's correct, yeah.
Thank you. And Premier, you faced some criticism for calling an election during the pandemic, and you said that decision was based on science and the modeling that was available to you. But if you're trying to avoid politicizing the science, why then seek Dr. Rahman at the panel with Dr. Fitzgerald during the COVID briefings, which are supposed to be apolitical, rather than just call a separate briefing to deal with it?
I'm not entirely following the premise of your question, to be honest, but as was answered before, Dr. Rahman is giving an update after an outbreak, the same as he did after the outbreak after the calls cluster. We felt that this was an appropriate forum. I don't believe I'm politicizing the science whatsoever.
Thank you.
Our next questions are from Sarah Smelly with the Canadian Press. Please go ahead.
Hi there. Dr. Rahman, were there things that really surprised you and stood out about this latest outbreak as you were doing this modeling?
Yes, thanks, Sarah, for that question. Yes, absolutely. So how quick the spread was, and the fact that so much of it was asymptomatic, and I was also pleasantly surprised in how the population reacted to it, particularly a younger cohort that must have stayed and abided by the public health measures, and how quickly we were able to, with a lot of effort, I realize, get down to a very low number of cases. So we need to really, again, like I said, respect the virus, but also have confidence that with the correct public health measures, we can take control of the situation. So surprised in both ends.
Thank you. And I wondered, so are we now considering this outbreak as being generated by a super spreader event, or was it just that it behaved like it was generated by a super spreader event?
No, so there was certainly events that happened over that first weekend in February that resulted in spread of this virus. Certainly, it behaved very much as a super spreader, so we would consider this to be a super spreader event.
Thank you.
Our next questions are from Peter Cowan with CBC. Please go ahead.
Just following up on that, we haven't seen any analysis on exactly how the virus spread, whether or not it was sports, other activities, school cases, and where it sort of was introduced. Are you able to provide any more details about that?
So we know that there were some events that happened over that weekend, sporting events that did result in spread to people who were at those events. And we know that because that was their only source of potential exposure. And then there were other sporting events that then, because people are involved in multiple sports, then some of those people became infectious in other events that happened as well. So there's probably a few different events that happened over the course of that weekend that did result in it being spread, certainly among that younger population. And then we saw those people then spread it into their households. And there were many, many households where everybody in the household became infected with the virus. So it certainly started as a super spreader event, and there was further spread otherwise as well. Eastern Health has certainly been working hard to make all of those connections. It's been a very, with so many cases and contacts, it's been a fairly intense exercise, and they are still working through that. And I'm hoping to have some more information in the coming days about all those connections. But it sounds like it would be very easy, but it isn't actually as easy as you would think, because you do have to consider symptom onset dates, potential exposure dates, to be able to make a timeline. So that can be quite intense.
Okay, thanks. Looking forward to when they are able to crunch all those numbers. Premier, I just want to go back to the comments that you made that all the data that you used around modeling, et cetera, was publicly available information. So why then, when Patrick Butler put an access to information request in there, was it denied, and the government's response was that these are cabinet secrets?
I have no insight into Mr. Butler's request for ATIP, and nor should I. But as certainly, I think the public would expect that cabinet committees discuss our COVID readiness. So I don't control the ATIP process, and nor should I. But and I mean, surely people would think that cabinet would discuss through committee and through cabinet itself the preparedness of the province for COVID-19.
Our next questions are from Peter Jackson with The Telegram. Please go ahead.
I really don't want to flog the issue, but this week I've been looking online, the Public Health Agency of Canada. They have an update every month on epidemiology and modeling. I've searched around a few other places. I can Google fairly well. I have yet to come up with anything that suggests what you suggested, the modeling you had predicted, Premier. So I'm just wondering whether you or Dr. Rahman or someone can point us to this publicly available information that you're talking about.
It's available on, I believe the update was December 15th or something like that, on the federal government public health site. And again, in the absence of cases here in the province, in our own jurisdiction, and our public health measures that were in place, you have to extrapolate from experiences elsewhere, with which Dr. Rahman had just said, and is exactly how I behaved, and that you interpret the natural order of the disease, of the virus, and escapes that happen take weeks to months before it hits a critical mass where you start to see an exponential rise. That's been the experience in other jurisdictions. We had less than 1 per 100,000. So it was, my opinion, that it was a reasonable extrapolation to assume that natural order would exist here in the province and take some time to hit a peak if it was to occur at all. Because we have shown, of course, that the public health measures here, as echoed by Dr. Fitzgerald and Dr. Rahman, have proved to be very effective.
Okay. Thank you. And I just have a quick question for Dr. Fitzgerald. We have people who are saying that they're getting conflicting reports from teachers as to how to wear a mask. Is there a good source somewhere online that people can get good information about for kids storing and wearing their masks?
So certainly the Public Health Agency of Canada has some good information about mask wearing, and we had a video as well, and I think it's still online, about how to wear a mask. And we had our infection prevention and control nurse specialist come on and show us how to do that. And there was a video that I did with at the beginning of the school year that talk to children and how to wear masks. So, and as far as I know, those are still available on our website. So there are some resources out there as to what's the best way to put on a mask, take off a mask, and you know, make sure you wash your hands and all those infection prevention and control measures that you need to put in place when you're doing that.
Okay, thank you.
Our next questions are from Richard Duggan with VOCM. Please go ahead.
Thank you, Dr. Fitzgerald. At the height of this outbreak, you mentioned that we weren't testing all of our new cases for variants at the time, or sending them off to be tested, because it just simply wasn't possible with such a high number. Now that we've seen our numbers dip down, we didn't have any cases today. We had one yesterday. Are all of our cases being tested again?
So any new cases that come in that are as a result of travel are getting tested for whole genome sequencing. And, you know, that is actually being done now at our lab. And we are validating the results with the National Microbiology Lab, but we are performing that analysis here as well. You know, so if we were to get information that one of our cases was a variant of concern, we would, from our lab, we would act on that as if it was. We wouldn't necessarily wait for confirmation from the National Microbiology Lab. We would behave as if it was, and we would respond accordingly. So, yeah, so at this point, any cases that are coming in from travel certainly are going to be done, are going to have whole genome sequencing. There may be some situations where we wouldn't do, like if we knew that there was, that a case wasn't a variant and then somebody contracted it from, you know, they were a household contact, we wouldn't need to do that whole genome sequencing on that case, because we know that their source would be, you know, the traveler who came in. So not every case will have to be tested, but certainly those who are as a result of travel will be.
Thank you. And we haven't seen any cases that I'm aware of that have been related to the Metro outbreak in some time now. I'm wondering, what's the criteria for determining when we can consider that outbreak over?
So we determine an outbreak over when it's 2 times the incubation period. So if we haven't seen a new case related to the outbreak in 28 days from the last known case, then we declare it over.
Our next questions are from Patrick Butler with Radio Canada. Please go ahead.
Hello. Question for the Premier. There's a lot of confusion surrounding the Atlantic bubble, the potential maritime bubble. Mr. Fury, have you said, what conversations have you had with the other 3 Atlantic Canadian premiers in the past week, and what's going to happen tonight?
I haven't spoken with any of them in the last week, but I will be joining them tonight to discuss the Atlantic bubble, maritime bubble, and including Newfoundland. And I'm quite hopeful that, you know, we can get there in the timelines that they're discussing. Our case numbers are going down. Our positivity rates are lower than some of the other provinces within the Atlantic region. So I'm quite hopeful to have a positive outcome in conjunction, of course, with the public health officers having their discussions. So that we can move towards an Atlantic bubble, provided, of course, the science supports it and it's safe to do so.
So does that mean that you believe it's realistic that Newfoundland and Labrador could join the bubble next month?
I do.
Thank you.
Our next questions are from Jody Cook with NTV. Please go ahead.
Thank you. Dr. Rahman, when looking at this predictive modeling, we really can see that the youth models obviously were significantly greater than higher age models. Does that make it a little bit difficult for you to then take this data and move it forward for making predictions for July and August, because the baseline has kind of changed a little bit with young people who were non-symptomatic and didn't require a lot of hospitalization?
Sorry, Jody, it's my fault. I missed the first part of your question. Can you just repeat it again, and apologize for this?
No sweat. The youth models being significantly higher in this latest super spreader, as we're calling it now, than they were in higher age models, which was what we saw with the calls cluster. does this make it a little bit difficult for you then forecasting for the summer and into the fall, perhaps, with the demographic being such a different change because your baseline has now changed for who has been COVID positive primarily, if that makes sense?
No, I'm still not getting the intent, I think, of the question. I just want to answer it appropriately.
I think given that fact that it's been linked to youth, does it make it more difficult to predict for the entire province moving forward? But I think it speaks to the black swanness of kind of this event as a supercluster and variant kind of outbreak.
Yeah, not really.
Thank you, Premier. Yeah.
So sorry, Jody. So when we're actually modeling what we're looking at are the cases, say over the last 2 weeks or so, to get a good trend in terms of what's going on. So what we really want to do is see a pattern and then project forward in the short term, and then using mechanistic models project in the longer term. And so each of the scenarios, we certainly learn from our previous experiences, and we certainly adjust things, but we rerun things based on the numbers that we see over the last few weeks.
Jody, do you have a follow-up question? Okay, our next questions are from Elizabeth Witten with All Newfoundland Labrador. Please go ahead.
Thank you. Compared to other provinces, we've never had many cases, 2 major clusters, and a little over 1,000 cases in total. So, Dr. Rahman, how effective can predictive modeling be in these circumstances with such little data to draw from to make predictions?
So it's a really good point, and it's helping in terms of pandemic planning. It's helpful in terms of healthcare resources utilization when we do actually have cases, but it's very speculative otherwise. So predictive modeling can help in many aspects in terms of, for instance, strategies for vaccination, in terms of strategies for screening, but in terms of predicting cases in both the short and the long term, without seeing significant community transmission, that is very hard to do. So you're correct.
Thank you. And Dr. Fitzgerald, I'm curious, when did the whole genome sequencing lab become operational?
My understanding is that it's been up and running as of Monday this week.
Perfect. Thank you.
Our next questions are from Sarah Smelly with the Canadian Press. Please go ahead.
Hi there. I'm wondering, we have people aged 16 to 59 who are clinically extremely vulnerable slated in our vaccine rollout plan to get a spot between April and June. I'm just wondering if things, given our changing vaccine situation, the AstraZeneca vaccine, et cetera, what will the soonest be that they're able to get their vaccination, do you estimate?
So our hope is now that we've changed and we're doing mainly first dose, at that waiting that 16 weeks in between doses, that we'll be able to move through those priority groups a bit faster and be able to provide first dose to people who are in phase 2 fairly quickly. Compared to where we were thinking before. So I can't give you an exact timeline at this point, but certainly, we are moving through those phase 2 priority groups right now, and we anticipate, in the next, in April, that we'll be able to make some headway there.
Okay, thank you. And then I wanted to ask, you mentioned Moderna is doing testing on children. How big of a concern is it for you, especially given what we just saw today, that children can't yet be vaccinated?
We know that just based on our own experience that young people can get this disease, and we know that they can spread it, and they often don't have a lot of symptoms and are still able to spread it. So it is really important from a community immunity point of view that we have young people vaccinated in the same proportions as we have adults vaccinated. With regard to the prevention of severe disease, that is important for some groups of children who may have more severe comorbidities. But we know that for the most part, children don't tend to end up with severe disease. So it's really the focus with immunizing children is really about increasing the immunity in our communities and trying to keep our communities safe. So we're very hopeful that those trials will give us some good information about using the mRNA vaccines in this age group.
Thank you. Thank you.
I will now go back through each reporter to see if you have one final question. Peter Cowan with CBC, do you have a final question?
I do, Leslie, and this one is about international rotational workers. Many of them are upset that they've been left out of the modified isolation, which gives domestic rotational workers more freedoms. I know that this is a federal responsibility, but I was just hoping to ask the three of the usual panelists, when was the last time you had any discussions with the federal government, and have you been pushing to try and get the federal government to bring in similar measures to decrease the burden for rotational workers who work internationally?
So we've certainly had some conversations, and since this has come up again, and in our conversations with our discussions, at the department with trying to find a new way forward for rotational workers, we've certainly had these discussions with people at the Public Health Agency of Canada, and in trying to determine, what our abilities are with regard to international rotational workers. And we still, at this point, our understanding is that we do not have the ability to override those orders that are in place. But we will be continuing to have those conversations in the near future, I hope, and I hope we can see a path forward. But at this point, we're not able to override those orders that are in place.
Peter Jackson with the Telegram, do you have a final question?
I have a quick question for Dr. Rahman. On slide 20, I believe it is, you show a bunch of variants. I just want to make sure, are these variants all variants of concern?
Sorry, no. So the only variant of concern there is the B117 variant. And so this is an mRNA virus that mutates frequently, and a lot of these are no different than the original SARS-CoV-2, and some of them actually may be less pathogenic. And so it's natural to actually see quite a few variants from this, or quite a few mutations related to this particular virus. And the only variant of concern that is there in that slide is B117.
Okay, thank you.
Richard Duggan with VOCM, do you have a final question?
Yes, Dr. Fitzgerald, I'm getting a lot of concerns from parents. Students in K-9 are returning to classroom tomorrow. Getting a lot of concerns regarding lunchtime and kids taking off their masks to eat. A lot of parents are wondering how this would be considered safe, with many pointing out the restaurants are still either closed or in some areas in the province operating at 50% capacity. Can you speak to those concerns and how this would be considered a safe activity for kids at this time?
So the first thing we got to remember is that kids are cohorted, and that they're going to be eating lunch within their cohort, which are the same group of people that they're exposed to on a regular daily basis. And so the whole point of us trying to keep our communities as safe as we can is to keep our schools as safe as we can. And so there's no activity that's going to be zero risk for anything that we're doing at this point, but we feel that we have reduced the risk as much as we can to allow the children to get back to school, which first and foremost is the thing we have to remember is what's important right now for children is to get back to school and to get back to those, to the learning that they're used to doing and to the social interactions and the social development that they need to have to be able to live well-rounded, healthy lives. So, the risk at this point in school is we don't see it as a big safety issue at this point, given where we are. We're watching things closely. If anything changes, we'll certainly respond accordingly. But at this point, being in school really is the balance of safety for kids.
Thank you.
Patrick Butler with Radio Canada. Do you have a final question?
I do. Question for Dr. Fitzgerald regarding tourists from outside Atlantic Canada. Considering most people in Atlantic Canada will have their first dose of the vaccine by the end of June, that people in, say, the province of Quebec will have their first dose of the vaccine by June 24th, what is your public health opinion of the risks of allowing tourists from Quebec or other provinces to come to the province this summer?
So we're still learning about how the vaccine will affect the transmission of this virus. And until we have a little bit more information about that, I don't know that it would be really prudent to comment on what we think should happen from a travel outside of the Atlantic bubble point of view. We've allowed travel within the Atlantic bubble largely because of the epidemiology that exists in the Atlantic provinces, not because of vaccination rates. We allowed it last year. There was no vaccination. So we need to remember the reason why we're allowing the travel within the Atlantic bubble if we do go there. But when we're talking about elsewhere, we still need to consider what the epidemiology is and what the effect of this vaccine will have on the spread. Hopefully by that time we will have that information, or we'll certainly have more information that's pointing to that direction. But without that, I don't think it really would be fair for me to make a prediction.
Thank you.
Jody Cook with NTV. Do you have a final question?
Yes, thank you. At this time last month, the public health was really pushing the download of the COVID Alert app, and that was very much incentivized by local business and so on. Do you have the numbers about of just how many COVID Alert app key entries were made of positive for notifications of people in the latest outbreak?
For the minister?
Yeah, Minister, I don't know if you have, I don't have that information.
No. Thank you, Jody. We know that there are just short of 7 million downloads in use in Canada, but we don't have a breakdown for this province specifically. Anyone who is positive is asked if they have the app, and if they have, they are given a key. Whether they use it or not has been a subject of discussion. I don't have any updated figures since the last time I was asked this question, but I can get them for you.
Elizabeth Whitten with All Newfoundland Labrador. Do you have a final question?
No, I'm good, thanks.
Sarah Smelly with the Canadian Press. Do you have a final question?
Hi, thanks. Yes, I'm just wondering, Dr. Fitzgerald, how you and your team are feeling now that it seems that you've swiftly beat back an outbreak that set records in Atlantic Canada for daily case numbers and active case numbers.
So I think our team and the team in Eastern Health are feeling somewhat relieved at this point. I think we're all still very much watching things closely and wanting to make sure that we stay where we are, but we're always on alert, and we'll continue to be on alert until we feel like we're sufficiently vaccinated with effective vaccines to reduce the risk of COVID-19. I think we also have to remember that it was in no small part a collective effort by everybody who abided by the measures and really worked hard to make sure that we reduce this spread as much as possible. We've seen in other areas where even though those measures have been put in place, if people aren't compliant, the spread still happens. So, I think it's a combination of a lot of hard work on everybody's part, really.
Okay, thank you.
Thank you, everyone. Premier, do you have any final comments for today?
Absolutely. Thank you all for joining us. Happy St. Patrick's Day. I hope the luck of the Irish is with us going into the next phase of the pandemic and vaccines. So stay safe, Newfoundland and Labrador. We will get through this. We are getting through this. So thanks very much for joining.
Thank you, Premier. Stay safe, everyone. Take care of yourselves and each other, and enjoy the rest of your day.
This is Jan. Jan sometimes visits her neighbor Paul. Paul has COVID-19, but doesn't know it. Jan also takes the bus. So does Mo, who's a frontline worker. So if Paul infected Jan, Jan could infect Mo, who could infect a lot of people. But wait, they all have the COVID Alert app. So Paul tested positive and entered a code in his app which anonymously alerted Jan, so Jan stayed home and Mo went to work safely. Phew, close call. Help break the chain of infection. A message from the Government of Canada.